Let's now talk about egg donation. So again, what are indications for egg donation? So there can be a poor response or egg or embryo quality issue that is a cause of their infertility. They might have some premature ovarian failure. For example, they were exposed to chemotherapy and their ovaries no longer function because they have no oocytes left. They might have just been genetically predisposed to their ovaries failing. They went through some surgical menopause for some reason. Maybe they had endometriosis and that they just kept getting sick. And ultimately, at one point in their life, the pain and everything was so miserable that they removed both ovaries. Maybe they had a granulosa cell tumor or some low-grade tumor that resulted in the loss of an ovary or both ovaries. Maybe they have some genetic disease that they cannot overcome, like I alluded to in the male side. Maybe they have congenital absence of ovaries. So maybe like someone with Turner syndrome actually wants to get pregnant. The only way they could do it is with egg donation. Now, obviously, someone with Turner syndrome who gets pregnant is a risk, especially if they have cardiac issues. So the decision to get someone with Turner syndrome pregnant using egg donation is a very measured and careful one that requires a lot of counseling. And then, of course, there's the situation of a same-sex male couple or even a single male. I've had both scenarios in my practice where a single male wanted to be a father or a same-sex male couple wanted to build their family. So these are some common scenarios for requiring an egg donor. Again, like we talked about, egg donation, in order to be an egg donor, you can either do it known or anonymous. And again, when we talk about the known situation, it's usually like a sister. It's rarely like my best friend or sometimes it's a cousin, but it's usually a sister or a brother in the case of a known sperm donor. It's rarely is it anyone outside. And yeah, sometimes I'll have same-sex female couples who have a friend that wants to be the sperm donor. That's not uncommon. The key thing to remember, though, is someone is a tissue donor. So a sperm donor, let me just make a comment about this. A sperm donor requires an FDA determination if he is not sexually active with the recipient. So if you have a boyfriend, let's say, and you're sexually active with that boyfriend, and you haven't been sexually active with him in the last year, but you want him to be the sperm source, there are obviously some parentage issues that both of you could be at risk for if your relationship is now good, but it dissolves later. But he does not need an FDA determination if you guys are sexually active. So I think that's the key question that I'll ask patients. So if someone's like, yes, I'd like to use this person as a sperm donor, my next question is, are you sexually active with that person or have you been in the past? And if they answer no to both of those questions, then they need to undergo an FDA determination. So coming back to this, again, known versus anonymous, we're going to start with the anonymous egg donor. So this is usually a woman who's under the age of 32. There's a BMI cutoff that's typically under 30. Some places it might be different. They have to undergo the FDA determination eligibility, which is the physical exam, the STD testing, and the questionnaire. It's the exact same questionnaire that we talked about earlier with the men. They undergo the genetic carrier testing. They have to be responsible. It's a lot more involved for someone to donate eggs as it is to donate sperm. Donating sperm is pretty straightforward. You masturbate, you're done. Donating eggs is basically undergoing the IVF procedure. You have to give yourself daily injections for 10 days. You're undergoing monitoring with blood work and ultrasounds, and then you have to undergo a surgical procedure under anesthesia. So it's a lot more involved to be a donor. And that's why donors get compensated significantly more than sperm donors. Let's keep going here. So I think it's important to understand that you can get egg donors come in. There are different ways to get an egg donor. You can get donors fresh. So you can recruit a donor through, like, for example, WashU has egg donors that are available. We don't really advertise for it. If this is something you're interested in, you can certainly contact the office. If you know someone who's done it, that's usually word of mouth that gets people to become donors. Usually people are kind of altruistic. They want to give to somebody in some way. In fresh donors, essentially what you're doing is you're going through IVF and all those eggs become the recipients. There are frozen donor banks, which basically collect all the eggs and allocate them into lots of like 6 or 8 eggs. And then they give those lots to the recipients. So you might make 30 eggs and those 30 eggs might be divided into 5 lots of 6 eggs each, and each lot could go to a different recipient. So again, that's fresh versus frozen. And frozen has really come online over the last 8 years because egg freezing was the experimental label has been lifted. So egg banking is more readily available. So here's an example of one of the largest, the original egg bank. So again, you can go and see how it works. You can find your donor, and it's not that different from how the sperm banks are set up. You can get senses of ethnicity, heritage, age, physical characteristics, and then you can learn a lot more about these people, both on the sperm side and on the egg side. You can get paragraphs, essays about why they're doing this. You can learn what their religion is. You can hear them in an interview. You can see baby pictures. It is endless the amount of information you can get. So if you were curious, that's where you could go. And again, I have no financial conflict of interest with that company. We do work with that company and another egg bank called Donor Egg Bank. So how do you decide what's best for you? So fresh versus frozen. In our program, fresh donors, some of the pros and cons. So let's talk about this. So let's make it real simple. So using a fresh donor gives you about a 65 to 90% success rate. That 65% is first cycle, and that 90% is cumulative. So that's after like one failed fresh, and then a subsequent frozen cycle. So basically you went through one fresh cycle, you weren't successful, but you had extra embryos to freeze, and you went through and transferred a frozen embryo. So that's pretty good. And that's regardless of how old you are. So a 42-year-old woman could have a 65 to 90% chance of pregnancy. You're looking at $24,000 out of pocket. That's about $15,000 for the IVF, because the recipient is basically paying for the donor to go through the IVF process. And we kind of showed you how much that is, plus the $8,000 for the donor. So $5,000 of which is pocketed directly by the donor. The remaining $3,000 is the fees that are associated with preparing the donor and administering the donor. So this $5,000 is pocketed directly by the donor. That's for her time and energy spent going through the process. So the recipient pays for all of this. The nice thing about a fresh donor is you get all of the eggs. So if they make 10 eggs, you get all 10. If they make 20, you get all 20. It can take time to get matched to one. There are donors here at WashU, for example, and if you don't like what you see there, you might need you might want a Jewish donor. Who identifies as Jewish. You might want a donor who identifies as Asian. You might want an African American donor. If those donors are not available, you might have to go to other agencies to find donors depending on your criteria. So that can delay the time it takes for you to be matched and to move forward. The frozen egg banks are good in that they can mitigate that matching, because the eggs are already procured, and then you might have more variety. So the downside is that you get fewer eggs, and as a result of the fewer eggs, you have still a very good chance of success, but it's just a little bit lower. But it is also less expensive. So frozen egg bank, you get 6 to 8 eggs, you got a 45 to 65% chance of success, and then you're looking at a $19,000 cost. Okay. And $12,000 of that is to purchase the eggs, and then approximately $6,500 is to inseminate the eggs, culture them in the lab, transfer them, and prepare your uterus for receipt of the embryo. So that's where the $19,000 comes in. Okay. So again, the decision to move to this hinges on, just counseling. And I talk to patients about both options, and we kind of make a decision and move forward. So special considerations about egg donation, we talked about known versus anonymous. If again, you are a woman who was exposed to chemotherapy, and you're in menopause and you're 33 years old, but your 25-year-old sister is willing to donate eggs to you, that's a route that's commonly taken in the known egg donation category. And in that situation, the sister is typically doing it pro bono, right? The sister is not asking you to pay them $5,000. They're doing it out of the goodness of their heart, right? Because they're your sister and they want to help their, sibling. So the cost is a little bit lower. Both parties go through reproductive counseling. There is no requirement for any legal contract or consultation, but if people want it, they can do it. And then basically the patients go through the process together as outlined below, whether they're known or anonymous, and then the embryos are transferred. So again, here's another scenario where understanding the menstrual cycle and the manipulation of the menstrual cycle is key. So let's talk about how we prepare and synchronize a recipient to the donor in a fresh setting. So when they're using a fresh egg donor, so they still have to procure the eggs, how does that work? Here at the bottom, we have the recipient, and then here at the top, we have the donor. So the donor is going to give us the egg, and the recipient is ultimately going to be the uterus in which the embryos are transferred. So you have to synchronize both parties, okay? In order to synchronize both parties, someone might have irregular periods. This one may not. They might both have regular periods, but they're not, one's cycle day is 2 weeks ahead of the other. So you have to synchronize them, and you accomplish that using birth control pills. So depending on what cycle day they are, you will go through, and once they start their period, you will start them on birth control pills, and you might give someone a longer length of birth control pills than the other. But the point here is you use the pills to synchronize them. Let's focus on the donor first. The donor basically goes through IVF. So in this particular scenario, we have the patient on birth control pills. We stop the pills, they have a period, and then they start their stimulation. Once their follicles get to a certain size, then they take the trigger shot, and then 36 hours later, they undergo the egg retrieval. 2 weeks after this, they're going to have a period. So again, 2 weeks after the egg retrieval, the donor will have a period. The recipient, they're on their birth control pills, they stop, and then they start their estrogen. And actually, they start their estrogen before this patient starts their stimulation, because you want the recipient's endometrium to be ready before the donor is ready. So they're usually on a GnRH agonist to prevent them from ovulating, because you don't want the recipient to ovulate, because if they ovulate, then that throws everything off. You would just have to freeze the embryos and then come back and do a transfer later, which is fine. But this the recipient is on estrogen pills. Once they come in for monitoring, if their lining looks good and they haven't ovulated, then they will start progesterone a day after the donor is triggered, and then they will take the progesterone injections, and then on the after 5 days of progesterone, on the 6th day, the fertilized egg, which is now an embryo, will be transferred into the recipient. Okay, so we're going to go over that again. So you'll hear that again down the road. Again, if you have any questions, we'll go over that one more time. So again, the point of the recipient is you want to prepare their uterine lining to accept the embryo. So in order to do that, you start the estrogen before the donor starts their stim. The patient is already on the GnRH agonist that they started while they were on birth control pills, like we talked about previously, and that's to downregulate endogenous FSH and LH production. So as a result, they will not ovulate. So you keep this patient on estrogen pills, about 12 to 20 days of birth control pills. They'll come in, check a progesterone level, make sure their uterine lining is trilaminar, and if everything looks good, then they're just waiting for the donor to be triggered. And when the donor is triggered, the recipient will start taking progesterone. The progesterone needs to be matched to the growth of the embryo, and that's done by starting the progesterone the day after the trigger. So after the day after the donor is triggered is when the recipient starts their progesterone. The egg is retrieved. The recipient's partner gives a sperm sample if applicable, and then the embryos are fertilized, or the embryos are cultured, and then on the 6th day of progesterone, the embryo is transferred. And then 12 days later, patient is either pregnant or not.